Jim Coburn, welcome to the show.
Thank you for having me. Thank you.
Oh, it's my pleasure. So let's start out. Why don't you tell us who you are and your superhero origin story?
Well, or our massive transformational purpose in life.
Also,
My name is Jim Coburn. I'm with, I operate an organization called Vigilance Health, there's a story behind that term vigilance. It's a very personal story around remaining vigilant around continuing to grow and continuing to help and be service of others. But what we do is we, under contract to healthcare providers, we provide population health management services, and that's a big, industry technical term that encompasses really one core service of care management to patients that are suffering from multiple chronic conditions, which is a very large portion of the U.S. Population. But in particular, it's mostly the senior population. And we have a team of clinicians that work with patients. It's all non-face-to-face. It's over the phone, and their primary role is to make sure that the patients fully comprehend their provider's directives, and they set up goals to help keep them on track with their provider's directives. And a lot of these chronic conditions that people suffer from, when managed well, it means that people can live very long, healthy, successful, lives, and they can stave off, some of the more miserable, consequences of what these chronic conditions can bring. And we also provide remote patient monitoring, so we can gather electronic data about these patients and push it to the provider, so that now the provider can kind of see trend lines of blood pressure and blood glucose and pulse oximetry and things like that, and they can absorb this data and modify care plans based upon data, rather than having little snippets of time, like, for example, their readings when they come in 3 times a year or what have you. And that's proving to be quite valuable as well. Go ahead.
No, so the theme, so we have an audience, some of whom are going to understand everything you're saying, some of whom might not get all of it, but the basic theme about all your services is you try and help providers, doctors, nurses, and then patients stay healthy rather than get a disease and get hurt. You want to help them use their medications and do whatever they need to do to follow a plan to stay healthy, so that it costs less money and people live better lives. That's your mission, as I understand it.
That is it. And our big transformational purpose is really to help people thrive no matter what their circumstance. And in the world of patients, oftentimes, it's one thing to go to your doctor and to hear the directives. It's a whole nother thing to understand what it means to actually put that into play. Like, if my doctor told me, I want you on a low sodium diet, for that matter, my first reaction would be, okay, well, does that mean I just don't add salt to my food? There's a big difference between hearing a directive and actually putting it into regular real world life. And so it's a really key role that we provide, because providers just don't have the time to shadow their patients or to give them that background knowledge, and then make sure that they put it into play. And so, yeah, that's it in a nutshell, what we do. But our lives completely changed a few weeks ago with COVID-19.
Oh, really? Did something happen a few weeks ago that impacted healthcare?
Yeah, it happened. And what was fascinating about it was that here all of our clinicians are working with the patients, keeping them engaged, setting up health goals, and all of a sudden, wham, stay-at-home orders come into play. And it's the elderly patients with chronic conditions that are the most at risk for COVID, although we're seeing that that's not the only group that's at risk, but they're the most at risk. And so all of a sudden, on a dime, all of our clinicians had to shift and just be nonstop COVID precaution education to these patients. While at the same time, they had to try to keep them on track with their chronic conditions. And it really is a kind of a fascinating dynamic. Everyone is having their experience, whatever that is, with this thing that we're all going through, and then we're starting to see the secondary impacts of what's going on with people's lives, and with the elderly folks that are having to shelter in place. It's interesting. They're not moving around as much as they were before because they're sheltering in place, but they're finding it more and more difficult to stay on top of their directives for their chronic conditions, which means that if they don't, that they're going to start to exasperate, get worse, and so the problems start compounding. I heard the other day on an interview that we're going to have the next pandemic, and the next pandemic is going to be mild to moderate and maybe worse behavioral health or mental health issues that will happen, that will come on as a result of what we're going through. And I don't know if that's true. I suspect there probably is a lot of truth to that. And so yeah, a lot of everyone's lives got changed, and that's how ours got changed.
Yeah. So can you give examples of, like, what are the kinds of things that are in orders for the elderly population that they're having a hard time staying on top of?
Well, so for example, I'll give the one that we found the most of is, and medication compliance is a big one, right? If you get some doctors together in, over a beer or over lunch or something like that, they'll say things like this. Oftentimes they'll say, when they're commiserating amongst themselves, they'll say, God, if I could just get my patients to just do what I tell them to do, I know that they're going to get better. Their chronic conditions are going to be better managed. They'll say things like this, right? Because they know it's tough. The first thing that they have the most difficulty with is making sure that the patients are adhering to their medications. And the reasons for their lack of adherence are many. Number one, it could be they're on 15 different medications, and it's not like every one of them is morning, noon, and night. Some of them it's morning and night. Some of them is just morning and noon. Some of them is just noon. Some of them is just night. It's complex, and they got a bunch of different bottles. And I remember a few years ago, I was put on several antibiotics at the same time, and oh my God, even 3 bottles, I couldn't even figure it out, let alone if I was on 10. So that's the first area. Another reason for med compliance is that they're not getting their meds refilled on a timely basis. They're just either not on top of it, or maybe they couldn't, get in to get them refilled or get to the pharmacy. And so, these are patients that if they don't stay on their blood pressure medication or their blood sugar medication or whatever, if they start having spikes, they now have to leave the safety of their home and get into a very dangerous place, which would be a waiting room full of other sick, potentially COVID positive patients. We don't want that to happen. So of course, but there are a myriad of other things. For example, a lot of times, they've got simple weight loss goals. They're not asking their patients to drop 100 pounds, although some of them, that would be the ultimate goal. They're just asking to get moving and drop 10 pounds. They don't really understand, they need a coach, a Sherpa, somebody to kind of get them going and keep them going on that one. And also staying on top of their activities for their key performance indicator, for example, blood sugar. So being really, really regular about checking their blood sugar. And those are the types of things that a lot of patients have difficulty staying on top of. And if we can move the needle on that, then we know that we've got a shot at building on top of that. It's just like anybody that where a modest goal is set and they meet it and they're like, okay, I can do this. Then you set another little slightly more aggressive goal. Okay, I can do this. All geared around staying on top of their provider's directives, of course.
Yeah. So because you are another thing about you that's really notable is you come from a family of doctors. and so you've grown up around it, and that's really the culture that you know. And so where I'm coming from in this question is, what's it like being a doctor right now?
Well, that's really interesting. So another benefit of this crisis that we're going through is some family, I mean, ours started to get a little bit closer in terms of our communication. So we're on an email group and a text group. And so for example, my brother is an emergency room physician here in California, and he's constantly giving us updates. And now they're waiting for the wave right now, and it looks like it may have just hit them about 5 days ago or so. I can tell you that the level of anxiety is high. And for example, when a couple of the physicians contracted or got COVID-19 and had to be admitted in their own hospital that they have privileges at, it shook everybody up. And they both, in this particular instance, had to be put onto ventilators. They were that sick. And so, so my brother, gives me a lot of kind of updates from his angle. My sister is, head nurse, at a large hospital in Los Angeles, and so she's adding her angles, and neither of them have complained about the fear of not having PPE, personal protective equipment yet. Although I'm sure that's in the back of their mind, they haven't complained about that yet. But the last message I got from my brother, which was just a couple of days ago, was very, very interesting, and I think it really got me thinking, and I think it should get everybody thinking about this. He sent a text and kind of a long text, and it was a description of the fact that he just had to put a patient into a drug-induced coma so that they could get him onto the ventilator. And just prior to doing so, he had to connect him with family, and it had to be over the phone because the family can't be anywhere near the patient. Of course, he's positive for COVID-19, and he's really, really, really sick. And they had to have their conversation, and he didn't tell me the content of the conversation. He left that pretty much up to my imagination, but he ended the text with, this patient is going to need a miracle and a prayer. And I got to thinking about that. I know enough about this that when a patient needs to be put onto a ventilator, you don't have hours. It's not like when you're that sick, you got to get onto the ventilator pretty quick. You don't have, okay, so tonight at 10 o'clock, we're going to put you on a ventilator. So you've got 10 hours to call family and, all that. You got to make your calls now, and they got to get you on the ventilator. They got to get you into the drug-induced coma, get you onto that ventilator. And, I got to thinking about, you can't help but think about how tough that conversation had to have been, and how much, how much that family wished that they could have had more time with him. How much, and maybe after that conversation, wished that maybe they said one more thing to him, but they don't have time. They don't have time. And everyone knows, I don't know if they're talking about it because I wasn't a fly on the wall, but everyone knows that there's a chance that he's not coming out of this. And so that conversation is the last.
Yeah. In
that case. And it reminds me of something that a really good friend of mine, it's kind of his mantra. And he says, nothing is guaranteed. Nothing. Tomorrow is not guaranteed. Our loved ones are not guaranteed. This whole thing is on loan to us. And if we don't act accordingly, then we just may live a life of regret, and we just may be in a situation where, where we were wishing we could have had a little bit more time, or wishing we could have said certain things that we didn't get around to saying. And because it's not like you get sick and you got 3 weeks with them and you could be at their bedside holding their hand. It's not like, it doesn't go down like that.
Yeah.
And so
you know how close I am with my mom. I think you've met her before.
yeah.
And so, she's 91 now, and
Oh, wow. Yeah.
she's in a nursing home. I haven't seen her in 5 weeks now, because
Yeah.
they closed it off to visitors before we had the general lockdown.
Yeah.
And at the time I'm like, wow, I don't know how many weeks until I see her. But the reality is, it could be a year before I see her.
Yeah.
The only
Right.
people they're admitting, which is sad but makes sense, is you only see your loved one if they're actively dying. Otherwise,
Right.
you don't see them. And on the one hand, it's frustrating. On the other hand, thank God, because I know if I can't see her, that's the chance of keeping the virus outside of her space. And
Right.
I call over there, the nurse will put the phone to her ear, and she doesn't quite understand who, I mean, she recognizes my voice, but it's when people are in certain situations, they don't connect as well unless they see your face. But what else are you going to do? So I'm really glad every time I see her, I make eye contact, I give her a kiss, I tell her I love her, and because I really never know when the last time is going to be. So make every time count and have no regrets. So that's always, it shouldn't take COVID to teach us this, but if it
No.
does, so be it, right?
Yeah. Yeah.
So
Right.
it's a great message, Jim.
Yeah. And it once again, it prompts this thing that keeps kind of showing up about every hour for the last 3 weeks, or however long this has been. This thing that keeps showing up is a question that starts like this: if there was ever a time I should, or we should do X, Y. I mean, if there was ever a time to remind us of X, Y, Z. I mean, I can't tell you how many times we've been able to answer that question with some very, sometimes fundamental, sometimes very impactful, answers. And oftentimes, oftentimes this is the kind of stuff that it takes. It's sad, but if you look on the look at the positive side, then we may all maybe operate just a little bit differently. I went to go deliver groceries to my mother's house the other day, and it was just so weird. There she is, 10 feet away. I said, Mom, I don't think it's a good idea if I come any closer. I would love to come give you a hug.
Yeah.
But I'm sorry, Mom, I don't want you to make me sick. No, I'm joking. I said I could have it, and I don't want to give it to you. No, we joke about that. I think my mother's going to live forever. She's 85 years old, and she's got all of her wits about her, and she's got an incredible amount of energy, and it deludes me into thinking that I'll always have her. And I just know that that's not the case. And
yeah. Well, now, not that I see people very often, but when I do see people, it's always, this is my new handshake.
I love it. I got to practice that. I love it.
Exactly. Live long and prosper.
Yes.
So.
Yes, that's good.
It's the only thing that communicates. So shifting gears a little bit, from your vantage point, where you kind of help, you both help physicians and healthcare people, and you also help actual, I don't know, call them patients or just people in the community. Seems like you've had a good vantage point. Now that we're in this emergency situation, what are some of the rules you've seen that have been changed, the waivers that have been given, that maybe we ought to keep them waived once this is done? What have you seen?
Oh, very interesting movement that the White House and the Department of Health and the Centers for Medicare and Medicaid have done. They were very swift to to grease the skid, so to speak, and look at it. There have been, it seems like, hundreds of waivers that have been issued to not only free up healthcare workers where there may be shortages, and remove restrictions and regulations to get them in and in place quickly, but also remove restrictions on certain types of services that otherwise had a lot of restrictions and actually made them kind of prohibitive. For example, the whole move to provide care to patients via telehealth, telemedicine, and even telephone. And so it was kind of a blanket waiver that they gave healthcare providers that if you're not set up to do telehealth, which is of course audio and video at the same time, or telemedicine, I think telehealth, telemedicine, kind of synonymous. Then you can at least talk to your patients on the phone, keep them on track, and the reimbursements will be similar to, if not the same as, if they were coming into the office, which is a phenomenal thing, because what happened as soon as the shelter-at-home orders went into place, everyone stayed at home, and a lot of people, even if they had appointments on the schedule, and the shelter-in-place orders said stay at home unless you need to go to the doctor, they were just still scared to leave the house, and probably was a good move to not go in. But there were waivers that allowed the providers to just get the communication going with their patients, no matter what way they can do it. They also kind of relaxed HIPAA laws so that providers could just use whatever video platform they could use just to get the connection going with the patients. The key was clear, that what they did is they looked at all of the things that might get in the way of providers connecting with patients in other ways other than face-to-face in an exam room, and they did everything they can to remove those waivers. There's still a few waivers that haven't been touched yet.
Before we go to that, just for our audience who's maybe not as up and aware as HIPAA as you and I might be. So right now we're doing this interview on Zoom, which is a great platform and everyone's using it. But in healthcare, the standard has been either GoToMeeting or WebEx, because the end-to-end encryption level met HIPAA requirements, right? So
right.
A lot of the telehealth initiatives, and that's just one example. So there were a number of things that, in order to be a telehealth application and a hardware platform, you had to make sure that there was a certain level of encryption, there was certain levels of redundancy, and I don't want to bore our audience, get the whole list of it, but you couldn't just buy a $15 or $20 Zoom package and you're good to go. But they gave a waiver and said, any way you can connect, it's an emergency, so we're going to relax those standards. And so on the other side of it, maybe some of those standards make sense, but you know what? Maybe some of them don't. So just cluing in our audience. So you were saying that there were some more waivers that you were thinking should be considered?
Well, yeah. So for example, and I have to, everybody can say what they want about government and the feds and the slow wheels of all that bureaucracy and all that kind of stuff, but they have done a pretty good job of scouring all the regulations, and it is so clear that there are hundreds of regulations that make it difficult to see and treat patients in other ways other than the traditional face-to-face, and there's layers of regulations, layers for ambulatory clinics, meaning not inpatient. There's layers of regs for hospitals, and so they missed a few. For example, one area is that what they really ought to be doing is they ought to go headlong into every type of service that can help keep patients on track with their chronic conditions, while at the same time addressing the potential COVID surge. And that's their biggest fear or concern right now, is the COVID surge. But we've got these underlying things, and that is all that other normal care that needed or that continues to need to be provided. And so there are, for example, with care management services, there's still some regulations that make it kind of difficult for organizations to provide that to all of the patients that that could be benefiting from it. And so, but I believe with a little bit of urging and maybe even a little bit of cluing them in, hey, you forgot a couple. I think that they'll probably do it. And in a way, I mean, it's sad that we had to have COVID do this, but really COVID did for us in a couple of weeks what the telehealth or telemedicine industry has been trying to do for years. And that is get this into the primary basket of tools that providers can utilize. Because it is a phenomenal way of keeping the patients in what otherwise is a relatively safe place, sheltered at home, not at risk of being, infection with other patients, like in an emergency room or in a clinic waiting room, and so. I hope that these waivers will remain. Something tells me they most of them will remain because the value is there. They see it, and COVID's not going to go away immediately. One of the governors just likened it to rather than it's not going to be a light switch being turned on or off. It's going to be more like a dimmer switch.
Yeah.
That dimmer switch might get turned right back on really, really bright for certain hot spots, and meaning that they'll have to, put in some really stringent stay-at-home, shelter-at-home orders for a given, region or location or city or town or whatever. Maybe that might be the way it goes, and so therefore these waivers. We're going to need these waivers to continue to see and treat these patients in the safest place for them to be, which is in their house.
Right. You bring up a really good balancing act that we've got to consider. So, the main thing is we don't want all these people to die, but it's not just enough that they don't die of the virus. If they die of their high blood pressure or their diabetes symptoms, they're still just as dead. And so, and if they don't have their medications and then they get COVID versus if they're good with their blood pressure and what have you, then it's that much more important, right?
Right.
So in terms of, let's shift a little bit about to all the other things are getting falling by the wayside around just general health. One of the things I'm hearing anecdotally is that people's quote unquote elective surgeries are being canceled, and that depending on what kind of provider you are, you can't go to work either, even though you're a doctor and you're trying to help patients. Can you talk about that a little bit?
Yeah, so I can. The problems are going to start mounting. It's one thing to put off a non-emergent procedure, but it's another thing to delay that in a really protracted way, because some of those procedures are designed to tell the providers something more about the patient's condition, and that if they should be acting on something quicker or not. Just take colonoscopy for that matter. Colonoscopy may not be an emergent procedure, but if it's delayed for any protracted period of time, and and they don't catch what they need to catch, we know that can have serious consequences. And there's all different kinds of procedures you can throw into that category. But the concentric ripple effects of that order is amazing. So not only do you have patients not getting those procedures, whatever they are. They could be surgical procedures, they could be diagnostic procedures. So not only are they not getting that, but the very service line that many health systems and hospitals use to offset the costs of their low insured or underinsured is now gone. Overnight, gone. Now we know why they did that. Why they did that, it has a lot of merit. They they need the equipment or the PPE for for those procedures to be placed over in the highest need, which would be hospitals or health systems that are experiencing the surge. However, those very hospitals that would be experiencing the surge are struggling financially, and in some cases they are on the verge of going out of business and can't pay their bills.
Yeah,
because of that order.
Let's deconstruct that to make sure that the whole audience can get that. So your example with PPE, if someone has hip surgery scheduled, that surgeon needs to use a mask and gown and variety of other protective gear that is in short supply. So that would be taking it away from an emergency room doctor that needs that to treat somebody who's got COVID. That makes perfect sense. The other piece of it is all these hospitals have emergency rooms, and what people don't understand is they lose a lot of money on those emergency rooms. Yep. So now those emergency rooms, let's say in New York City, are probably 5 times as busy as they are normally, and they're very busy normally. And the hip surgery that would normally happen, which is an important thing to do, that hip surgery isn't happening. So the money that they would make, and they make a profit on that hip surgery, they don't have. And that hip surgery is what's subsidizing the emergency room doctor. And so you're basically losing money in an area where you're spending a lot of resources, and you got the person who's waiting for the hip surgery who's in a lot of pain. And so short term, it makes perfect sense. It's kind of like, yeah, if you're in a boat and and it's taking on water, you put all the resources to closing up that hole. But there's at some point you have to make sure that the engine is still going, or you got a new set of problems, right?
Yep.
So that's essentially what you're saying. I hope I'm not.
Yeah. Right. That. Yep. So not to mention the fact that there is a toll that happens to a patient that now has to continue to wait for something that is already having an impact on their quality of life. And when they're in that state, then the spiral starts. Then the anxiety or depression kicks in. And when the anxiety or depression kicks in, people are at much higher risk for another stroke if they had one before, and a decline in their other chronic conditions if they happen to have them, and it really begins to exacerbate itself. So there's the personal toll, and then there's the financial toll on the healthcare system, and this is this is a big challenge. And one that I think that there's going to be a lot of really good exploration and study around, so that we can be better prepared, in the future.
Yeah. So, I mean, I would think that the protective gear is something they're going to solve much quicker than some of the other problems. So that, that shouldn't be a reason long-term why we wouldn't be able to do this. The bigger problem is, and I know I've heard in Israel they're doing this, in New York I hear they're doing this, segregating the hospitals between, if you've got COVID, go to hospital X. If you've got anything else, you go to hospital Y. So I know that, you can't put off a baby being born. So the OBGYN is happening according to nature's schedule.
Yeah, right.
So they're putting that, that in a different place. So it seems like we're going to have to do that with our facilities, at least for a little while. And when we ramp open some of the more, you might call them elective, but people are going to need their colonoscopies. People are going to need, I don't know what you call that level of procedure, but there's a level of procedure between, like, let's say a Botox injection on one end and a colonoscopy or a knee repair or something of that nature on the other. There's different levels of elective, right?
Right. Yep. So yeah, exactly. And there are a tremendous amount and these are elective, and it's almost, I even hate to use the word elective. It's just that it's just non-emergent, and so it's everything else. It's everything that's not emergent, right? But there's a lot of things that are really critical to our long-term, quality of life and well-being, above and beyond all those cosmetic stuff. There's a lot of procedures that are important, that just aren't getting done now, and they're backing up and backing up and backing up. And meanwhile, the other toll is the providers that provide those kinds of services are basically stopped.
The irony is, you would think that the one sector that's going well would be healthcare, but you'd be wrong, right?
Yes, right, exactly.
The parts of healthcare that's going strong are the money losing part of it.
Yes, exactly. Yep.
So you're
right.
burning through all your cash, and you might think, well, we can't worry about profit at a time like this, but all those healthcare professionals, if the hospital can't keep the lights on, that's a serious problem, right?
Yes, exactly.
So from your perspective, what do you see, like, kind of peek around the corner for us, and what do you see next around healthcare, and what do you think the next level of problems we're going to have to solve are?
Well, like I had mentioned, I do believe there's going to have to be some emphasis put onto to addressing some of the mental health issues. There may be a lot of folks that get into a fog here in this period that don't get out of it quickly. And we all know mind, body, spirit, it's all one. And you just cannot separate your mental health from your physical health. One has a gigantic impact on the other. And so I believe that for those of us in healthcare, we're really, actually everybody, we're going to have to address it. And everybody is in a different place, and some people may suffer a little bit more than others. But the other thing is that we're going to have to really find a way to keep these folks that are the highest at risk on track and continuously in touch with our healthcare system. And right now, that means all of the activities that allow them to stay at home, because that for right now is the safest place, and it will continue to be the safest place for as long as until we have some type of a vaccine. And so from a healthcare standpoint, I don't see shelter at home being anything permanent. I don't mean to say that, but I believe providing care to patients while remaining at home is going to have to continue for the foreseeable future, until there's some kind of a way in which the most at risk can interact with everybody else in the way that we always have been. Until that time is, we got to keep them safe, but we also have to keep them on track with all of their other conditions. And so I see people getting really innovative and creative around providing that care and continuing to provide that care in that way, just so long as we can keep the insurance companies and the payers and government to fully understand the importance of doing that, which would mean that they would have to keep those waivers in place, so that so the healthcare organizations can do that and get paid for it.
Okay, so that makes perfect sense. What is it specifically around Vigilance? Like, we've all had to pivot, and we're all changing our focus from what it was 2 months ago. What are you and your organization focusing on now, and what's it been like for you?
Well, so it's been, it's almost, when people, when friends or or colleagues or people not in healthcare ask me how I'm doing, oftentimes I say, we are busier than we've ever been times 1,000. And the reason for that is because of the sharp pivot to keep these folks educated on their precautionary measures. Oftentimes these are patients that, these are lifelong patterns of behavior. We have a lot of seniors that live pretty active lives. They're not all sitting at home, and they're not used to sitting at home. And then we got to kind of break through the misinformation that's been out there, the disinformation, the stories. And so it's been heavy COVID education and COVID precaution, around the basics of washing your hands, hand sanitizing, being very careful about who's coming into the house, staying on top of your provider's directives. And what we found is, because of the shutdown, when I say shutdown, I mean kind of I'm using that term kind of globally, in the sense that when the stay-at-home orders were put into place, well, that automatically, for all intents and purposes, shut down a lot of clinic organizations. What we found is a lot of the clinics, 50% of their staff overnight could not come to work. And it's not that they couldn't come to work because of they were sick. Kids were at home. You can't leave small kid. There's no daycare. There's no school. And so therefore, they couldn't even see the patients that were coming in. And so when we had the shutdown, oftentimes our care managers was the only connection to the outside world and the healthcare industry that these patients had. They couldn't get through to their doctors if they had questions. They weren't going in to see the doctors, and so we were the only kind of connection point to the healthcare industry, and we took full advantage of that to keep them well educated and keep their spirits high and keep them motivated to continue to take a more proactive approach to their healthcare while staying at home. And we found really is that this is a powerful tool. Without that type of service, these patients would be at home, and really there would be no education coming to them. The only form of education that they might get is maybe from an adult son or daughter. Maybe they're out of the state, and maybe the news. And what we found is that these patients needed constant education and re-education on the precautionary steps. So it really has changed things for us. And from that standpoint, I hope it remains the norm, because our the people that we are working with are so much more engaged today with their care now than ever before. And the reason is because we've caught their attention on the importance of taking actions, and now we're capitalizing on that to keep them on track with their other directives, which is, I'm sorry to say it, but COVID helped us out in that regard. It caught people's attention on healthcare.
Well, one thing I wonder, and I know how heavily regulated the industry is, so it may not be feasible, but I'm thinking, like in the old days, you might have a care coordinator that says, to help you with your blood pressure, it'd be really good if you did some yoga and if you did some, other things, and then you just sort of make a check mark to see if they're doing it. Now, I guess it's possible for you to organize an online yoga class.
Exactly. Yeah.
And you could actually provide some of the services.
Right.
Or partner with other, your local yoga teacher or with meditation practitioners, or, just whatever it is, you could extend what you're doing telehealth to tele-exercise.
Right, exactly. And now the other thing is that so many more people are used to, okay, let's meet online. Let's have a conversation online. We'll have a conversation over the phone, but let's meet online. And so people are much more attuned to doing whatever they could have done in the real world, and now do it kind of in the virtual world. And we're capitalizing on that as well, because everybody's forced into it. But the other thing that I was thinking about the other day is, what about all those adult sons and daughters from out of the state. You know, a lot of people grow up, move away from home, move away from their parents, and now their parents are elderly, and nobody can travel, or they're, you know, I mean, you can travel, but it's difficult. And so, who are they relying upon to help their parents? And I'm thinking that we really ought to look at ways in which we can bridge that gap between family members and you know, and elderly patients, and maybe open up a service like that, so that clinicians can kind of be their connection point to their you know, to their family. That might be something that we might roll out you know, after this is all over, or maybe in the midst of it all, because I know that.
Let me just make sure I understand what you're saying. So it's brilliant, actually, Jim. I love it. So if so let's say you've got someone's mom, let's say I don't know, Anne, who's 85 years old, and her son lives in Michigan. Normally, she would go to the doctor and they might have a conversation afterwards. But now, since you're doing telehealth anyway, when they've got the consultation, maybe the son in Michigan gets on the Zoom or whatever application together, and he hears the same thing he's telling Anne. So here's what you need to do to watch this and watch that and watch the other thing. And then even though he's in Michigan, he could actually ask the question, okay, doctor, so mom really loves these kind of bonbons. Is it a problem for her, or isn't it? Or they'll say, you know, she's been doing this kind of exercise. What do you recommend? And they could actually get engaged. Is that what you're talking about?
Yes, exactly. And then now everybody can take a proactive role, and we don't have the problem of, okay, mom, how did it go with the doctor? Well, I can't really remember everything that he said, you know, that kind of thing. So now the son or daughter can take an active role. And if we add care management to it, now their son or daughter has access to somebody who's helping to keep the parents, you know, on track, and can kind of be their eyes and ears, for lack of a better term. And, you know, whereas, you know, I even look at it like they may not even be out of state. They could be just 3 hours away. That's difficult at a time like this to go make the drive. Not to mention the fact you shouldn't be coming close to your adult parents right now, just because, you know, anybody can be a carrier, as they say. And and so to have those resources, that's being done, you know, from a telehealth or telephone or whatever, to have those resources can really help the you know, the family members to know, okay, all right, so I have somebody looking out for my parents' meds. They found the pharmacy that can deliver. They're connecting them with the doctor. I can climb on at the same time that the doctor is, and I could be right there with them. And yeah, so I think a lot of good can come out of this, so that the family can help to continue to be playing an active role in the care of their family members.
Is this a service you can prototype? Is there,
so yeah, that is something that we would love to put together. And you know, it's been kind of rolling around in my mind, thinking about the family members of these people that we're helping, and they're out of the loop. And but we can bring them into the loop, and I think we would like to put a prototype like that together.
If you think about it, having the care coordinator be the kind of convener of the video conference, and having the doctor or the nurse have the conversation with the patient and whoever, and make sure all the paperwork is authorized. So from a HIPAA perspective, the disclosure is allowed. Yes, I want my son to be able to do this. Yes, I can do this. So then they make sure the paperwork's taken care of, and then they convene the meeting, and then whether it's allowed to be recorded or not, but in theory you could record it. And then you've got that information, as long as, you know, all the rules are that's a brilliant idea. I love it.
Yeah. Yeah.
That's wonderful. You know, I'd love for you to come back and talk about the program once you launch it, and
I'd love to.
What you're learning. That's beautiful.
Yeah.
I love that. So what else can you tell us about, you know, what's going on in Ventura, and what are the providers dealing with above and beyond what we've talked about?
Well, so what's interesting is we're able to see the landscape of almost the entire state of California now, because we work with 25,000 patients up and down, and that number will probably grow to about 50,000 patients over the next maybe 4 to 5 months, and all up and down the coast, and from the Central Coast to the Central Valley to Southern California and on up. And things are a little bit spotty. I can tell you that the sentiment for people up in the Central Valley is that this problem is an over there problem, kind of like the way we might think of Syria. You know, there's a civil war going on in Syria, and there are hundreds of thousands of people dying, but it's over there, and I don't know what we can do about over there. So there's a little bit of that we're trying to break through, what's helping to break through is the news is coming out that it's hit basically every county in California now in terms of
cases.
Yeah, cases. And so, but the shelter at home orders, even though that sentiment exists in spotty areas, the shelter at home orders have covered the entire state. And pretty much everybody has listened to those shelter at home orders, or at least a lot of people have listened to it. And it's really affected healthcare organizations dramatically. And, you know, we've had a lot of clinic sites that have just closed. Now, not entire clinic organizations, but clinic sites that have just closed. For one reason or other, they either didn't have the staff to come in because they're all having to take care of their children, or no patients are coming in. And so, private practice doctors have had to, well, really everyone has had to pivot to providing care to patients over the phone or telehealth. And some were able to do it, much quicker than others. And we were hearing from some organizations that they're just now gearing up. It's difficult for these guys to all of a sudden flip into a virtual organization, which is the term being used now. And it's difficult. The workflow is different, and a lot of the providers, what we're being told is that it's okay for me to be on the phone with a patient, but I really feel like I'm handicapped because I can't see what their vitals are today. And I'm so used to, when the patient comes in, that the first thing that the medical assistant does is they escort them back, and on the way back, they're taking all their vitals, their weight and blood pressure and what have you. And now I don't have that. And so they really feel handicapped. And so telehealth or telephone that still doesn't solve that. So we're trying to solve that gap with remote patient monitoring equipment. There is some really cool stuff out there right now. And for example, we have some equipment that is an integrated pulse oximeter, blood pressure cuff, blood glucose meter. Right out of the box, it's already configured to the moment you take a test, or you put the blood pressure cuff on and it takes the read, it automatically sends the data straight over 4G, which is cellular. We don't need 5G for that. So it automatically
probably don't even need more than 3G. You're just
exactly, because it's little pieces of data. It's not it's not like you're sending video or even voice for that matter. Yeah. And what's cool about it is it automatically transmits it right into our care management platform, which then has the display right up. We push it right into the provider's or the doctor's electronic health record. And so now they can see and they can track the daily figures. And so this will enable them to see these key vital numbers that they would normally see when they see the patient in the exam room. And so we're trying to get that out, as rapidly as possible. But, some of that equipment is made in China. And so there's so not all of it, but what's great about that is that the patient doesn't have to configure anything. They just open the box,
just put it on, and
put it on, press the big round button on it, and it automatically takes the read and sends it. And so and we see a lot of providers are gonna want and really need that if we have to see the patient at home for a protracted period.
That's pretty interesting. And I wonder, I wonder how that's all going to evolve. I mean, like, I know I've been wearing the Apple Watch for a couple of years, and I get a lot of those readings. They may not be to the level of reliability to the instrument you're talking about, but if a doctor has a choice between nothing and some basic data, I think they'd want,
Oh
they'd want
yeah.
to get whatever information they can get, right?
Yep, yep. And these days, that those readings have gotten better and better and better on the the Fitbits and the Apple Watches. They've gotten better and better and better. And these are these are diagnostic quality reads these days. And
Yep.
so yeah, we're in the process of integrating that data as well. And so that way that we have a collection of data that the provider can have at their fingertips.
Yeah, it's going to really make a big difference.
Yeah,
So once we're talking about that, let's get into it. One, as you know, a couple of years ago, I lost 100 pounds,
yeah.
and
Congratulations, by the way. That's
thank
great.
you. Well, what a lot of people don't know is you were one of my inspirations. I mean, the thing that I love about you is you're just so rigorous about exercise, and you're a little bit younger than me, but not that much younger. And you're always, oh, guess what? I'm parasailing this weekend, or you're hitting a new personal best in terms of the weight, and you're lifting, not having, but
Yeah.
and then
Yeah.
you'd have your struggles, your frustrations about how I was just so much stronger 10 years ago, 15 years ago, but you just it was very inspirational to me that you, however busy you were as an executive and working, you made sure to get those things in. You were careful about what you ate. And so I took on, as swimming every day and measuring the different pieces. And what I came up with this framework around winning the day. So I took a couple of measurements. One is, did I track everything that I've eaten? Did I weigh myself in the morning? Did I stop eating in a certain time? Did I eat less than a certain number of carbs? And did I swim that day? And so if I did 3 out of the 5 activities, I won the day. And if I won 5 days a week, slowly but surely I would get to my goals. And one thing I definitely learned from you is to set the goals and to try and win as many of your measures. So will you talk a little bit about how you win your day and how you set up your life to succeed?
Well, so what's interesting about that, I love that, winning the day. God, that is so powerful on several levels. And it kind of comes back to the 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 point that I was making a little earlier. Nothing is guaranteed for us. Tomorrow is not guaranteed. Next year is not guaranteed. Our our loved ones in our lives are not guaranteed next year, and anything can happen, as we're seeing now. And winning the day is, so the reason why I love that so much is because all we have is today. And I know it's been beaten up and said so many times, but it's just so true. This is all we have. We have today. And I know this sounds ridiculous, but I once I started to live a life of a little bit more contemplation through quiet and meditation. What I found is that whatever your religious beliefs are and whatever your your persuasions are in terms of a spiritual practice or whatever, God, and whatever God you want to call it, is really only in the present. And our life is only lived in the present. And to live it in the future or to live it in tomorrow is actually delusional. And to be wrapped up about the past is also delusional. It really actually doesn't exist. And a friend of mine told me one time, he says, if we spend a considerable amount of our time stressing about tomorrow or racked about yesterday, pretty soon we're completely living in la la land. It's not real. It is, and so therefore it's not sane. And so to know that we are in today, and to live in today, is where all the change takes place. So to win the day, I think, is such a powerful message. And so, so for me, so I did happen to take on another sport. And now I'm going to contradict myself a little bit. So, kiteboarding and kite surfing, which is it is just such a a phenomenal experience because you are connected to literally all of the elements, the wind and the water and the waves, and you're powered by the wind, and you literally must be constantly present to all of the elements at all times. It is impossible for your mind to wander into tomorrow or into yesterday, because you have to be in tune with and be one with the wind and the kite and your board, and so I do as much of that as I possibly can. I do have to, since it's weather dependent, I do have to look at the forecast for tomorrow and the next day. And so I'm going to contradict myself a little bit. But once I get out there, I'm just completely present. And what I've found in the area of of physical exercise is that I had to find activities that were fun, or else it was just going to be a slog and I would end up failing at it. I had to find some activities and create some fun around it. And so I finally did find ways of having some fun at the gym. But that all had to be mixed up with other activities, and so for example, racquetball and kite surfing and a little bit of gym where I couldn't fit those in, and so what that does is that constantly keeps my blood pumping and the endorphins moving, and it's a daily process. I don't set gigantic goals for myself. I just keep setting small goals and just kind of build upon them. And yes, there's a retraction, but I think I'm going to apply your win the day. I love that.
Take it.
Yep, I'm going to take it. And what I'll do is I'm going to source you for about 6 months, and then I'm not sourcing you anymore. I'm just going to be mine.
Fair enough. That's good.
I'm joking. I will always source you, Martin.
It's all right, man. It's all right, man. Well, that's awesome. But the other thing I really admire about you is, from a business perspective, you're willing to try stuff, like the idea we just talked about. You're like, oh, I think this is a good idea, but let's see if the market agrees. And you'll go out and you will call your providers, and you'll call your community and say, I'm thinking of doing this, and this is kind of what I think about the price point. Is this going to work? And you try it, and you do a campaign, and you call a whole bunch of people. And if it works, great, we got a new product line. If it doesn't work, well, nothing ventured, nothing gained.
Right.
So,
right.
Yeah, I'd like you to tell our audience a little bit about that philosophically and how you do that.
So, that is kind of interesting, because I tell my team this a lot. I have to I always have to find, like, I have to calibrate my words around this, because as a leader, you feel like sometimes that that you want your people to kind of admire and respect your leader, right? But oftentimes I have to tell them, listen, I don't know anything. And so therefore, if I don't know anything, then that means that I'm open to learn anything. And if something's not working, or if we've got an idea, I don't know if it's going to work. Let's just figure it out. How else? And it's really fun, because it makes life and business like painting a painting on a canvas. I mean, I'm not a good painter, but I can imagine what somebody who sits down with a clean canvas begins to think about in their minds. And what is that? How is that going to materialize? It might look good at the end, and it might not. But oh my God, if you just stared at a blank canvas all day long, nothing would get done. And that's what's really fun in working with team members, because everybody's got a different mindset. But oftentimes I see people kind of paralyzed by, if we don't have all the answers, then we shouldn't start. And that is the unfortunate thing, is we're never going to have all the answers. And not to mention the fact that I don't have any answers. And so, but what if we could do this? What if we could do that? The whole what if stuff is so much fun, because you start watching the sparks start to fly. And And it, what if this is another really corny thing, but what if you knew that you were never going to fail? What would you do? Oh my God. I mean, that just opens up everything, doesn't it? So, that kind of thought process and remaining in that kind of childlike state of being, somewhat naive and, we don't really have all the answers, enables us to have fun at work. That's number one. But number two, really find, come up with some unique ways of solving problems that currently exist. And so, yeah, it's a constant process of creativity and just shedding ourselves of what we think we know. And in doing so,
I gotta say that's one of the things I'm trying to learn from you, and not letting the perfect be the enemy of the good, and just do something good.
Yeah.
So, yeah, I'm just trying to channel my inner Jim Coburn. And
I love it. I love it.
Go for it. So I'm stealing that from you. So
all right.
It's all good. I'll keep sourcing you though, no problem. So let me close with this. What is it you'd like to leave our audience with?
Well, I think number one, I probably don't need to, to tell people this, but I just find that there's a little bit of an inner tugging. And it hit me when my brother sent me that email. And that is, if nothing's guaranteed and tomorrow's not guaranteed, then how would we operate differently? And what would we do with our family members? And if there was ever a time, I love this, if there was ever a time that I should ... it is now. What is that? What would that be if there was ever a time? And the great thing is that I can apply this to my personal life, to my personal relationships, and I can apply this to healthcare and to business. If there was ever a time to help people do XYZ, it is right now. If there was ever a time, really, this question can be applicable at any day of any time, but right now it's got a special significance to it because of what we're all going through. But I think that question should live on. Really, I hope that it lives on with me and in our organization and in our culture.
I totally agree. All right, well, let's close with that. Thank you so much, Jim. And why don't you come back once you've prototyped that service? We can talk about it.
We'll do. We'll definitely. Okay.